Thank you all the Retina team here for giving me this opportunity. And I want to thank Dr. Venkatesh sir and Adia sir, first of all, for allowing me to do the fellowship here in this institute. This is the place where I started my career in Retina. I am very thankful for this. So my topic is preoperative evaluation and risk factors. And then by proper preoperative evaluation, we have to ensure the patient safety. So as all of you know, the endophthalmitis is a dreaded complication where the infected organism gains access into the eye, it proliferates, and then excites the inflammation, and that ultimately causes the damage to the all tissues of the eye. So it is the risk and the impacts are, it's a very devastating complication with the incidences ranging from 0.04% to 0.02%. And even the incidences underreported and clusters are often underreported. So we have to be, the incidence may be little high also. And depending upon the various procedures like intravitreal injections, intravitreal like traps, every surgeries are associated with their own risks and complications and their own prevalences and incidences. So broadly, we can classify the source of infection from patient-related factors, personally of the OT, or surgical supplies or instruments and operating environment. Simply say men, mission, and environment. Men, mission, and environment. If these things are working in harmony, everything is fine. If there is disharmony, there is a disaster or accident. So preventive measures, what we do is patient preoperative measures. We have to take the patient screening for metabolic disorders, proper ocular examination, and prophylactic use of codeine iodine. And intraoperative, where the precisions and your protocols will protect you. So you have to, surgery should be very precise and your protocol should be very stubborn and in the post-operative care you have to, all these areas you have to succeed to prevent the endophthalmitis. So why the preoperative systemic workup is matters is you will be setting a stage where for your success here. So most of the failure for your failures, there is a cause there. You will be identifying your failure causes preoperatively, and then addressing them will make you a success. So by proper preoperative evaluation, we will be preventing intraoperative and postoperative complications and thereby reducing the chances of infection. Identifying the infection risk factors before surgery itself and addressing them will reduce the risk factors for endophthalmitis. Ensuring optimal systemic health for better healing. So after surgery, the healing should be proper. If there is delayed healing, there will be risk of endophthalmitis. Reducing the chances of endophthalmitis and poor outcomes should be addressed. So the key preventive strategies are like we will follow this first systemic risk factors should be addressed. Then conduct the thorough ocular examination before the surgery, and then use the povidone iodine 5% drops for antisepsis, and then ensure proper patient hygiene before surgery and avoid contact procedures on the day of the surgery. We will go one by one. So the patient-related factors, if you see like advanced age and premature birth, so both extremities of ages are the big risk factors. Diabetes mellitus, hypertension, chronic illnesses, severe malnutrition, skin and severe burns, skin diseases like atopy or acne rosacea, all these are the risk factors. Open wounds or any infected wounds, like we see a lot of diabetic patients who will have a wet gangrene or some skin problems. All these things should be addressed and taken care, and any trauma is there, it has to be addressed properly. So bronchopulmonary diseases, COPD, chronic obstructive pulmonary, circulatory impairments, malignancies, immunodeficiency states because of the drugs or irradiation or HIV. All these things, if you see all these things, you have to do a battery of investigations where the cost of the investigations will exceed your cost of surgery also. The patient may not like. So what is the, so our Cochrane review database published by this Levy et al., they have shown that all this battery of investigations you need not do for a ocular surgery. So a targeted, first good a systemic history, and then good physical clinical evaluation will target you to a desired investigation. So do the needed investigations. So that you can reduce the investigation costs and the surgery costs. So you have a self-administered health questionnaire, and then based upon that targeted investigations you have to do. So the key components, it has to be addressed by the trained MBBS doctor or physician at least. And we have to do the metabolic profile evaluation, cardiovascular and general health clearance, infectious disease screening and immune status, nutrition and hydration assessment, and special considerations for high-risk patients. So metabolic profile, most of the common is like diabetes. If patient is non-diabetic, well and good. If patient is diabetic, you have to plan your surgery ahead of 3 months. So that if the sugars are very high, you can gradually reduce the sugars, and then if the surgery is not an emergency like a pacomorphic glaucoma and all, you have to reduce the sugars gradually and then do the surgery. The fasting blood sugar you should it should be less than 140, and random postprandial is like less than 200, and ideally HbA1c 7% is described, up to 8.5% in UK, and it is accepted. So the thing is like gradual control. Controlling the blood sugar is very easy if you give the insulin, but the sugars comes down. But that is not the way you have to do the in elective cases. We have to gradually reduce the sugars over a period of 3 months, and then take up for the surgery. So the blood pressure. So hypertension is the thing which actually the hypertension that are for doing the surgery, it is less than anything between 160 to 95. Ideally 140, 80, but ideal things are very difficult. So at least up to 160 to 160/95 is the cutoff. So if the patients are having metabolic disorders like diabetes or hypertension, you have to take control of the lipid profile and all. So nutrition and hydration assessment should be done properly. Cardiovascular is ECG if patient is above 50, or echo if there is cardiac issues, and physical. So fever history we usually tend to underscore, but patients with fever may be sufferers, or sometimes preclinical stage it will be like carriers and all will be there. So all this screening protocol, the best way to screen this fever is complete blood counts, urine if the is a thing which we usually look for. The complete blood count, hemoglobin should be like we say anemia is not a big thing but anemia for is a greatest culprit, because if the hemoglobin is less, not only the surgery is difficult because the patients may not tolerate surgery, even the wound healing process requires proper hemoglobin levels. So WBC count less than 4,000, you have to look for immunostatus, and you have to address the WBC count 11, greater than 11,000. It is points towards the infections. So if the platelets are less than 1 lakh, you have to address the coagulation disorders and then take up for the surgery. If there is 5 lakhs, you have to address for the thrombotic episodes. So dental caries, there will be common question coming from the patients is like, we have the dental treatment appointments, can we go for the surgery? So the logic behind the dental caries is like, it may, when they undergo the treatment, the septicemia may happen. But the other thing, what we usually, when the wound is raw, these dental procedures, they use the scalers and drillers. So the scalers and drillers will cause the droplet. So when the wound is raw and these droplets splash onto the eye, this may cause the infection. So immediate post-ops, I recommend not to go for the dental treatments. So special considerations, usually elderly patients are the thing. In these elderly patients, you assess the mobility, cognition, and compliance. So ocular risk factors, we are all very thorough in these ocular risk factors like lid abnormalities, lacrimal drainage system infection, conjunctivitis, contact lens wear. So you have to address the blepharitis, lid malpositions, ectropion, entropion, and you have to assess the lid closure, lag ophthalmos and all. So lid infections, hardiolum, canaliculitis, chalazion, nasolacrimal duct. So these syringing procedures you do not do on the day of the surgery. It has to be done prior and properly addressed. So conjunctivitis on the day of the surgery, you have to postpone. If the patient is using the contact lenses, you have to use avoid using the contaminated drops and all these things. And sometimes you may miss very low height blebs and all. You have to be careful when you are doing examination, and infected buckles may be hidden there. So you have to customize your prophylaxis treatment according to the patient needs. Not like every patient will be bombarded with all the antibiotics and all. And in future, AI, if you give the data of the patient, AI may predict this much percentage of risk is there for this patient, and you have to do these things. So in future, AI may play a big role. In conclusion, a well-structured preoperative workup focusing on ocular hygiene, infection screening, and prophylactic antibiotics significantly reduces the endophthalmitis risk. In India's high surgical volume and variable infrastructure and patient hygiene factors require extra vigilance to maintain optimal infection control. Thank you.